video interview. I was very impressed by your presentation before. I'm not sure to have understood everything. As what I saw, you do 3 sequential surgery on the same patient. I understand that you have to deal with very severe complexity. And how is the outcome of this patient after 3 surgeries in such a short time?
The outcomes are typically very good, better than what you would expect. So there's the initial recovery from surgery, which takes about a week. So if you do, for instance, surgery from the front, patients take 3 or 4 days to get better, and then the surgery from the back, it takes through another 3 or 4 days. So they might be in the hospital 10 days total, 10 days, and then they go home, and then they're actually doing quite well. They're already better by the time they leave the hospital many times, and they come back 3 or 4 months later, and their fusion, in the back has healed up, and they're much stronger. Everything is getting better at that point, and they continue to improve over a year or more. So the experience has been very good.
So how many cases of craniocervical instability do you operate for a year, for example? Which is the percentage as compared with Chiari normal malformation,
right,
simple
correct,
one?
Correct. In my talk, I think it was I've done 102 standard Chiari operations is over 15 years, and about 30 of the more complex ones where it's the fusion and the odontoid removal. We are all parents of children or teenagers with this disease. Do you find that did you find any differences between children and teenagers about the craniocervical instability? In Chiari, so I have to separate out because I see patients with trauma, tumors, and so forth. Those are usually very young. With the Chiari patients, most of those kids are teenagers that are unstable. Severe compressions, and it's been there for a long time. There are once in a while, it's unusual, but there's occasionally a 3 or 4 or 5-year-old that comes in that has a Chiari and a congenital bone problem that needs to be operated on. So it's more the older patients in this category.
Yes, and did you notice any correlation with the EDS syndrome, as Miller had said? Yes,
I have not seen a patient with Ehlers-Danlos syndrome.
Because we checked through our Italian association, and we asked to the Italian Association of EDS syndrome, and we asked how many Chiari patients do we see, and they told us none. We have never seen a Chiari patient. We don't have this evidence. Is it possible that EDS syndrome is only a cause in the settling of this disease? Because this is probably a multifactorial disease.
I agree. I don't know the answer to that, I'll be honest. It may be one of those situations where you don't know the answer till you try to look for it. There's an association, so you start looking at it in more detail, and then you can really find out if it's 2 separate problems or one problem.
Another question, sorry, about the surgery. For how long time did you follow your patient? Which is the mean time of follow-up?
For the fusion patients?
Yeah, for the fusion patients.
So I would say starting about maybe 10 or 12 years ago, so I'd say the average follow-up is probably 2 to 4 years. 4 years average follow-up. Anywhere from I did one a couple of months ago, to 10 years. So long follow-up.
And so they are fine, they can do
they have done remarkably
exercise,
well.
They can do sport, they can do athletics.
Yes.
They are. And we have a question. Do they have the orthostatic before.
I have not seen it.
You have never seen it. So which are the typical symptoms of those boys and girls and before the surgery?
Many of them have sleep disorders, swallowing problems, weakness or numbness in their extremities. Some of them are completely asymptomatic too, but typical symptoms would be those headaches.
And how do they read? So because we have seen every kind of MRI and TC and so on. So prone, supine, sitting, up, down. What do you do? Because our children usually do a simple MRI and maybe a dynamic one, and nothing more. So maybe we don't know. Maybe our patients will have an instability and we don't know. And maybe they are treating only for What would you suggest?
Well, that's a good question. I see patients. There was one patient I showed in my talk that had the odontoid. C2 was retroflex, pushing against the brainstem.
That you can see.
But the bone wasn't that bad, but there was still compression, which I think was from tissue that was trying to stabilize the joint. And I looked very hard in her to see if she was moving, if she was unstable, and I couldn't find any evidence of it. So I don't know why she had that, but I think that's the body's response to an unstable joint, to try to form a mass of tissue to stabilize it.
So that means that you decide to do a surgical operation only when you have only clinical evidences and you suspect something.
Correct. You were talking about what different types of imaging to get, prone, supine, sitting, standing, and I don't do those. I do simple MRIs. I use a lot of CT scans, look at the bone anatomy, and I just listen very carefully to the patients and their families and kind of what symptoms they have, and I spend a lot of time with them. And if they have significant compression and their histories are significant, there's no doubt that decompressing them and taking care of them, they're going to get better. They're definitely going to get better. So, there's probably a certain percentage of patients that are very difficult to figure out no matter what. Should you really do an operation or not? Because it's a big decision. It's a big decision.
Are you planning to do any genetic study, such as, or to join to the main lineage analysis?
I don't have any plans right now to join in the studies, but I have friends who are participating in those studies. Yeah.
Because our idea as an association would be to promote these genetic analysis studies, because we know it is a multifactorial disease, multi-genetic disease, and so to increase the sample size is crucial for this disease. And we would like to propose our patients, our groups and the medical doctors to collect the DNA, to collect blood, extract the DNA and send to the centers.
Yes.
That would be a good point. Also, if we could probably possibly arrive to a consensus, of course, for a diagnosis of this disease, such as EDS and L1, L2, and so on, and hypertension, hypertension, and all these other things. That could be very useful for us. I've been very interested because Milano talked about the fibrillin gene. Someone else on yesterday talked about the FGF2 receptor, and this morning they said FGF3 receptor. So that means that for sure something about collagen. But what do you think about hypertension? Have you ever had any patient with Chiari 1 that were not simple Chiari, but they were the results of hypertension or hypotension?
Intracranial hypertension.
Yes.
I've seen several patients with hydrocephalus and Chiari. I mean, lots of patients with tumors and so forth. So sure, I mean, I've seen that before. And then the intracranial hypotension, I've seen that too. I've seen both. Yeah.
And so, what do you do for hydrocephalus?
You treat the underlying cause. You treat the hydrocephalus. You treat the hypotension.
And what for the borderline? Because we know that there is idiopathic hypertension without either eye, swallowing eye. Have you ever had any cases like this? So, clinical sign of hypertension without hydrocephalus?
Yes, I've seen those. You talk to pseudotumor patients?
Yeah.
Pseudotumor cerebri patients? I've seen those patients as well. Most of those patients don't have Chiari malformations in my experience.
And what would you suggest
for pseudotumor?
For those patients?
They're very difficult to treat.
So, I think that the research must probably go on. And, we have a work of you by Dr. Valentini, who is very impressed by your work. And we would like to thank you very much because for sure I think that you will be you will stay in contact with Italian medical doctors, and we will all benefit from your expertise and your research and your work. So thank you very much.
Thank you. It's been a very educational conference. It's been wonderful. Hopefully there'll be a second annual and a third annual, and keep it going. It's wonderful.
Okay. So thank you.
Yeah, thank you.